So, what about treatment? Often there is a team approach, and because there can be a lot of actually somatic things that come along with this and gastrointestinal problems, you have usually professionals from a lot of different domains supporting the individual, and professionals that help address different aspects of the disorder, like speech, being able to work, being able to deal with the body, and then nutrition has, there's certainly some different diets that have been posited as more helpful. When you use reinforcement to increase a response, it's necessary to wait for the response to actually happen to emit it. Now, if you are an abstract thinking adult, the shaping doesn't come into play as much because you can say, hey, touch your finger to your nose, and you can understand that cognitively and do it. But for something that either rarely never occurs, or if you have an animal or a child, shaping can be used. That means that you reinforce successive approximations to this desired behavior. So you get reinforcement as you come closer and closer to what you're actually supposed to be doing. So here's an example, and this is actually teaching mute children with autism or schizophrenia to speak, because you can see there's a little bit of a change in cognition from an abstract thinking adult. Training begins with having the child imitate the trainer's voice to encourage. So to encourage this, the child's reinforced simply by looking at the trainer's mouth. But when the child accomplished this task, the trainer modeled the sound and reinforced the child only when he or she made a vocalization. Eventually, the child's reinforced only for imitating the particular sound. And then once the sound is mastered, the trainer introduces a new sound, and this procedure was continued until the child's able to say words and speak in simple sentences. With a pup, that could look like anytime they get close to their ball, then they get a treat. Then it can be, once they've really mastered that, it's when they touch the ball with their nose, they get a treat. And when they've mastered that, it's when they pick it up and bring it to you. So it progressively. So chaining seems similar, but it is actually different than shaping. Skinner described this as three-term contingency, the sequence of discriminative stimulus, behavior, consequence. He says this is what accounts for actually the acquisition of most complex behaviors, including behavior chains, which consist of a number of distinct responses. So making a cake would be an example, or eating a plate of food, let's say. First, if you're a kid eating a plate of food, this is actually there's actually a number of steps to it. First, you have to pick up your fork. Next, you have to learn to scoop some of that food onto your fork, get it on there. You need to learn how to get that fork to your mouth. You need to learn to chew your food. You need to swallow. So some of those are pretty automatic. A cake is an example that is a little bit more complex. But the establishment of both of these behaviors are referred to as chaining. You really get your big reinforcer, such as eating that food, it going into your tummy, or getting to eat your cake at the end of the chain. And chaining can happen forward or backward. So you can start with the first component, like teaching the kid how to hold a fork or a spoon. But you can also use the reverse order. And in this example, it's a little bit harder, but you could think you put the food in the kid's mouth first. Then maybe you have the spoon is already in their mouth and you teach them to hold it. So you could go backwards or forwards. It's sometimes confused with shaping, and that's because they both have to do with establishing complex behaviors, but only the final behaviors of interest in shaping. So I want the dog to be able to bring me that ball. But I don't need her to be able to be near a ball. I don't need all of that kind of stuff. But in chaining, every step of that is important. So the pup getting the ball might be a behavior change, but teaching her the word ball is shaping. Interventions incorporate a variety of strategies, including parental management or parent management training, special education, training in self-care and social interactions, vocation training, and placement using sheltered workshops and supported employment. Not listed here, but shaping and discrimination training are the behavioral techniques that were originally used by Lovaas in the 1960s, and these are the two techniques that you'll often see being used to improve communication skills. But there's also a lot of interventions that have been developed to really try to help these individuals be able to function normally and live happy lives. Applied behavior analysis is one model for working with autism. Functional behavior analysis. These are interventions to behavior change that result, function-based interventions are the result of a functional behavior analysis. And these are basically conducted to determine, all right, some kid is hitting the wall in class. You are really wanting to look closer, like they're doing this undesirable thing. We wanted to substitute something more desirable, but you have to know what they're getting out of that. Are they getting approval from their peers? Are they getting attention from the teacher? Are they getting attention from their parents when they go home? So to do that, you might have observation, indirect or direct. You can have interviews and just any sorts of data that can give you information about the behavior and what the antecedents and consequences of it are. The ultimate goal is to decrease or eliminate undesirable and increase something alternative. So it's not just extinguishing a fear response with PTSD. It's really having very specified and alternative behavior that's desired. So with PTSD, it really could be, you could think of it as the alternative behavior is relaxation. So it is possible to think of it that way. But let's say with dogs and the bell, with Pavlov's experiments, that the bell no longer creates it. That's not a functional behavior analysis. Functional behavior analysis, you also want to increase something positive because there's something not positive happening. So with school psychologists might do that if there's a lot of issues with a particular student and talk to the student, talk to their teachers, go watch the class, and maybe they find out, hey, when he's doing something really a boring task, he's doing that to avoid working on the boring thing. So how could you intervene then? Well, maybe you can modify their assignments, give them more of a choice, give them a way to complete them that's going to help them to be more interested, and reinforce them for staying on task. So they're not, so that the not having to do it was reinforcing them before, but maybe now they get cookies when they do their task, or whatever, probably not cookies in that case. So then the psychologist is going to evaluate the effectiveness using a single subject design to compare their frequency of on-task behaviors during baseline and treatment phases. The stimulants are used to treat ADHD primarily, although there's other things included on this list. Just make sure to know methylphenidates, Ritalin, and pimodulins, Cylert. Those are the most important. And what do? They make norepinephrine and dopamine more accessible, and that's the main cause of action. It can cause restlessness, and if you use too much for too long, it can cause psychosis. The side effects can be psychosis and can even look like schizophrenia. Withdrawal can cause agitation and hallucinations if there's a lot of use. And finally, stimulant drug holidays are really important because they can suppress growth in kids, and since a lot of kids take them, it's important that they can get a break. Contingency contracts. application of reinforcement to naturalistic environment, addresses problematic interactions, and negotiate contracts. So what does that all mean? This is an application of contingency management that involves a formal written agreement between two or more people. So it could be the therapist and the client. It also could be teacher and students, etc. And you clearly define the behaviors that are to be modified and the rewards and punishments that will follow performance of them. So behavior change may be required by one or all parties to the contract. So let's give an example. If you have a therapist and client, then you'd require behavior change really by the client only. But if you have a contract between two spouses, then both people need to be making changes. According to Stewart and Lott, there are 5 elements necessary that this is going to be effective contract. Okay, first, explicit definitions of what each party is going to receive as a result of meeting responsibilities. Second, there should be sanctions that are clear if you don't meet the contract's terms. Third, behaviors need to be something that can be monitored. So be nice. You really need to operationalize what that means to be nice. So if it's complimenting 5 times a day, then that's something you can monitor. Fourth, the contract should define bonuses for consistent compliance with the terms of the contract. So if it's meditation, let's say you and your spouse agree that you're both going to meditate every day. If you meditate 5 days in a row, there's a bonus for having done so consistently. And the 5th is a record-keeping system to keep giving feedback to both parties about the frequency of behaviors and also so you can actually deliver the appropriate reinforcers. They're most effective when the person whose behavior is to be modified is actively participating in the development of the contract, because if this is getting handed to you by your teacher, that there's going to be more resistance. They're not fully on board. So there might be some good to it, but in general it's not completely helpful. Finally, let's talk about social skills training. Social skills training is used to improve communication, assertiveness, problem solving, all sorts of things that have to do with being socially adaptive. And this is a type of behavior therapy. And it's different from, it's not just operant though, it's classical, operant, and social. So it's really kind of coming at things from all angles to focus on better social skills. So that might include modeling, coaching, rehearsal, feedback, reinforcement, assignments, all sorts of techniques. And the idea is that it has to do with using these techniques to develop social skills. We know that people are getting less natural life training being behind the computer with Facebook, especially kids who maybe didn't grow up and have that socialization, and now they're behind the screen and maybe skills are lagging, but they're there. So kids especially might really need a lot more informal social skills training, if not social. This can help with schizophrenia, conduct problems, depression in all ages, and is really great when incorporated into a multimodal treatment. Self-reinforcement. Self-reinforcement is when you are administering the reinforcement to yourself. So this is something kids do for sure, but I think it especially brings up the image of adults who are trying to do weight loss or trying to lose weight, and they monitor themselves using records. There's apps on the phone now, and they start to also control their environment stimulus that they encounter to narrow the range of responses. So 2 self-management procedures is just self-monitoring and stimulus control. Those are the two pieces to really know. Self-monitoring is what you usually do initially, and this is done with CBT a lot. You're recording things, getting information about the nature and magnitude of the behavior, and that also can help you develop what your treatment is going to be before you kind of move on to stimulus control and all of that kind of stuff. Stimulus control basically means that your behavior is under stimulus control when doing it is contingent on the presence of something else. So, cigarette smoking is contingent or controlled by things like drinking coffee, talking with friends, being alone, or even having a pack of cigarettes. So when you want to use a stimulus control technique, you're altering your associations between the stimulus and the behavior. So narrowing is restricting the target behavior to a limited set of stimuli. So you can only smoke at 5 p.m. after work. That's not a great one because usually people who are smoking are trying to get rid of it altogether. But let's say with trying to lose weight, you only eat at meal times. You're not snacking and running into the kitchen and putting your hand in the bag of chips all the time. Cue strengthening. That's when you link a behavior to specific environmental conditions. Eating means sitting at the table. Studying, if you want to increase something like studying, then you cue strengthen. So when you go to your desk in the office, you study. So cue strengthening is more about increasing this particular behavior. Narrowing is usually restricting the target behavior to a limited set of stimuli. And fading consists of changing the stimulus conditions associated with the behavior. So this might be when a cat is trying to chew on your hand, you put a cat toy in their mouth. And this could also work if you have fetish objects. Give them something more appropriate. So Meichenbaum and cognitive behavior modification. Two programs associated with Meichenbaum's CBM are self-instructional training and stress inoculation training. Meichenbaum's approach tends to focus on self-statements, or the verbalizations that clients make to themselves. Like Beck, his approach emphasizes collaboration in a Socratic style of questioning. The interventions described below are going to be okay, so we're staying with Meichenbaum, actually, and we're going to start with his self-instructional training. Meichenbaum and Goodman in 1971 originally used self-instructional training to help impulsive and hyperactive children perform academic and other tasks more successfully by teaching them to interpolate adaptive, self-controlling thoughts between a stimulus situation and the response to that situation. Self-instructional training, or SIT, incorporates the work of Vygotsky and Luria, who propose that true voluntary behavior does not occur until there's a shift from external to internal language control, as well as Bandura's work on observational learning. And there are 5 steps of the therapy. Cognitive modeling. The client observes a model perform the task while the model makes self-statements aloud. Self-statements include questions about the nature of the task, answer to those questions, specific instructions on how to do the task, and self-reinforcement. Second, cognitive participant modeling. The client performs the task as the model verbalizes the instruction. So you could also call that therapist verbalization. Overt self-instruction, or patient verbalization. The client performs the task while instructing him or herself out loud. Fading overt self-instruction, or patient silently talks through task. The client whispers instructions while carrying out the task. And finally, covert self-instruction, or independent task performance. The client performs the task while saying the instructions covertly. There's a slight parallel here with protocol analysis. Protocol analysis is a procedure that's used when a person is learning a task and is asked to describe aloud the steps being taken to solve the task. Protocol analysis is used to gain access to people's problem-solving strategies. Tourette's Disorder is characterized by the presence of at least one vocal tic and multiple motor tics that may appear simultaneously or at different times. They may wax and wane in frequency, but they have persisted for more than 1 year, and it began prior to 18 years. For many individuals, the frequency, severity, and disruptiveness declines in adolescent or adulthood. There are associated symptoms of Tourette's, and most commonly, those are obsessions and compulsions. The rate of OCD is higher not only for those with Tourette's, but also for their biological relatives. Hyperactivity, impulsivity, and distractibility are also common and have been identified as a cause of the high rate of school problems that are exhibited by children with this disorder. So what's the etiology of Tourette's? Well, it's been linked to elevated levels of dopamine and supersensitivity of dopamine receptors in the caudate nucleus. So how do you treat it? It usually involves pharmacotherapy and the antipsychotic drugs haloperidol and pimozide. That's been studied most extensively, and they've been found to be effective in about 80% of cases, actually. A drawback of their use is the potential for negative side effects, and many patients find those intolerable. In addition, an SSRI is usually useful for alleviating the OCD symptoms that accompany the disorder. Note that because psychostimulant drugs have been found to increase tics in some individuals, the hyperactivity and inattention that often accompany Tourette's is treated instead with clonidine, which is usually for hypertension, or desipramine, which is an antidepressant. Finally, comprehensive behavioral treatment for tics, CBIT, is an evidence-based treatment for children and adults with Tourette's and incorporates habit reversal training, relaxation training, and psychoeducation. So extrapyramidal symptoms are a combination of dystonia, akathisia, and Parkinsonism. But when you think of extrapyramidal, you could think of a pyramid shaking, because these are mostly movement things. So the traditional antipsychotics, they are used to alleviate positive symptoms primarily by blocking dopamine receptors, and this relates to the dopamine hypothesis that schizophrenia is due to oversensitive dopamine receptors. The most important, there's a few side effects, so remember 3. Anticholinergic, that's you're not peeing dry mouth. Extrapyramidal, that's motor stuff. And then neuroleptic, which is the rapid onset of motor and autonomic symptoms that can be fatal. So what is the mechanism of action? Well, we talked about it. It's a dopamine antagonist, so it lowers dopamine levels, and this is most helpful for positive symptoms. The atypical antipsychotics are also used to treat schizophrenia, but there's 2 pluses here. One, it helps more with the negative symptoms than the traditional ones do, and secondly, the extrapyramidal motor side effects are much less common, and they're less likely to cause tardive dyskinesia. So what are the negatives of switching to this one? Well, a negative is it's also more likely to produce or can produce a granulocytosis, which is a white blood cell problem. And both of them can do the neuroleptic malignant syndrome. But in any case, clozapine has also been found to be useful for bipolar disorder that hasn't responded to mood stabilizers. And there's a lot more uses for the atypical, including depression, alcohol, Huntington's disease, motor symptoms. And another disadvantage is that it has a slower onset. Tardive dyskinesia, this is about there's facial grimaces, involuntary movements. And neuroleptic malignant, this is like agitated, heart's racing, there's a tremor, it's kind of wild, then you can die and stop immediately. A granulocytosis, which is associated with the atypical antipsychotic clozaril, it will cause a sore throat and fever and can be lethal, but that's the white blood cell. The mood stabilizing drugs. Lithium and carbamazepine are the ones to remember. Lithium is the drug of choice for bipolar disorder, especially with manic, not for rapid cycling though. It suppresses mood swings. Lithium, we'll talk a little bit more about lithium in a moment. There are different types. So the 4 types to know about, or the 3 types, tricyclics, SSRIs, and MAOIs, but there's also other ones. The SSRIs are particularly effective for melancholic depression, and they're also prescribed for OCD, bulimia, panic, PTSD. They block the reuptake of serotonin. They take 2 to 4 weeks to kick in, and sometimes up to 6 to 8 for full effect. Be careful about serotonin syndrome if taken with an MAOI or other serotonergic agent, which it really shouldn't be. The tricyclics. So this was our first antidepressant created, and it's the most effective for those in particular that have decreased appetite and weight gain, or in weight loss, and early morning awakening. However, there's a high risk of suicide. These work by blocking reuptake of norepinephrine, serotonin, and or dopamine. This fits in with the catecholamine hypothesis, which says that norepinephrine deficiency is part of depression. The side effects are cardiotoxic and severe hypotension, which is a drop in blood pressure. Overdose can be lethal. So that's a major downside if you have a suicidal patient. The MAOIs include Parnate and Nardil, and they work by deactivating dopamine, norepinephrine, and serotonin. This is particularly useful for atypical depressions that are non-endogenous and have more vegetative, reverse vegetative symptoms, interpersonal sensitivity, anxiety. And they can cause, the most dangerous thing is they can cause a hypertensive crisis due to conjunction with tyramine, the amino acid tyramine. What would that look like? Well, a headache and stiff neck to start, but then just kind of like a flu, like nausea, vomiting, sweating. They need emergency treatment. So here's some of the new ones, NDRIs and SNRIs. NDRIs, Wellbutrin's the most popular one, and it's norepinephrine and dopamine reuptake. Depressive phase of bipolar. The good thing about it is it doesn't have as many anticholinergic effects and is less toxic, but it can aggravate psychosis given the dopamine element to it. SNRIs works on serotonin and norepinephrine, and this has also been helping people with pain. It's less dangerous than the TCAs and faster, but it can increase your blood pressure, so that's something to watch for. Zymbalta is an example. Beck's cognitive therapy is also referred to as CBT therapy and was originally developed as a treatment for depression, but has since been successfully applied to a number of other disorders, including anxiety, these are underlying cognitive structures and rules that consist of core beliefs and that determine how individuals codify, categorize, the primary goal of cognitive therapy is they're revealed in automatic thoughts to help clients identify and alter dysfunctional cognitive schemas develop early in life as a result of biological, developmental, and environmental empiricism. They can be either functional or dysfunctional, and may be dormant until they're activated by internal or external stress, especially stress caused by conditions similar to those under which they originally developed. Once activated, dysfunctional schemas impair the ability to think rationally and predispose individuals to depression or other disorders. Automatic thoughts. These are surface-level cognitions that intercede between an event or stimulus and the individual's emotional and behavioral reactions. Automatic thoughts are not necessarily associated with psychological dysfunction, but they contribute to dysfunction when they're the result of maladaptive schemas and are frequent, persistent, and then not critically examined. Cognitive distortions. These are systematic errors or biases in information processing and are the link between maladaptive cognitive schemas and negative automatic thoughts. Common distortions include arbitrary inference, which is when you draw conclusions without corroborative evidence, overgeneralization, when you draw general conclusions on the basis of a single event, selective abstraction, attending to detail while ignoring the total context, personalization, erroneously attributing external events to oneself, dichotomous thinking, thinking in polarized either-or ways, and emotional reasoning, believing things are a certain way because one feels they are that way. Like automatic thoughts, cognitive distortions become problematic when they are pervasive and are not critically examined or challenged. A cognitive profile. According to Beck, each psychological disorder is characterized by a different cognitive profile. For example, depression involves the cognitive triad of a negative view of oneself, the world, and the future, while the cognitive profile for anxiety reflects an excessive form of normal survival techniques and consists of unrealistic fears about physical and psychological threats. Characteristics and strategies of cognitive therapy. Cognitive therapy is distinguished from other CBT therapies by several characteristics. First, it relies on collaborative empiricism. This involves developing a collaborative therapist-client relationship and gathering evidence to test hypotheses about the client's beliefs and assumptions. Second, it is time-limited treatment, with the average length of therapy being 15 sessions and sessions being structured and goal-oriented. With regard to the latter, the first session ordinarily addresses the following goals. A. Establishing rapport and trust. B. Socializing the client to cognitive therapy. C. Educating the client about their disorder, the cognitive model, and the therapy process. D. Normalizing the client's difficulties and instilling hope. E. Determining and, if necessary, correcting the client's expectations about therapy. F. Collecting additional information about the client's problems. And G. Developing a goal list. Third, while the focus of cognitive therapy is on the client's current experiences, historical material may be addressed to clarify his or her core beliefs. Fourth, cognitive therapy assumes that relevant cognitions become accessible and modifiable only with affect arousal, and consequently imagery and other techniques are used to elicit affect. Fifth, questioning is a primary therapeutic tool and often takes the form of Socratic dialogue, which is also known as guided discovery, and involves asking questions that are designed to help the client reach logical conclusions about a problem and its consequences. Sixth, the relapse prevention is a focus throughout treatment. For instance, during the course of therapy, the therapist emphasizes the client's part in causing change in mood and behavior, and toward the end, the therapist works with the client to develop a self-therapy plan. CT incorporates a variety of behavioral therapy techniques. Behavioral strategies include activity scheduling, behavior rehearsal, social skills training, and relaxation. Cognitive strategies include the downward arrow, if so, then what? Questioning the evidence, decatastrophizing, mental imagery, and cognitive rehearsal. Clients are often given homework assignments, and an early assignment requires the client to keep a daily record of dysfunctional thoughts in order to identify the client's automatic thoughts. The specific techniques used in therapy depend on the nature and severity of the client's symptoms. For example, behavioral techniques designed to increase the client's overall activity level are often the initial interventions for clients with severe depression, while cognitive techniques are usually the initial interventions for those with mild to moderate depression. Attribution retraining, another cognitive restructuring technique. Attribution retraining focuses on altering the individual's perceptions of the causes of their problematic behavior, and this has been successfully used to treat depression, anxiety, alcoholism, and several other disorders, as well as to improve the academic performance of underachieving students. Attribution retraining is consistent with the assumptions of the reformulated learned helplessness model and with optimistic explanatory style that is promoted in Seligman's theory of learned optimism. Its goal is to help clients attribute their failures to external, unstable, and specific factors, and successes to internal, stable, and global factors. Problem-solving therapy. This is these are cognitive and behavioral strategies to help clients deal effectively with problematic external events. So stress inoculation is actually one of those. And then problem-solving therapy was originally described by Desirable and Goldfried in 1971. It's been updated many times since. Its most recent version proposes that problem-solving outcomes are determined primarily by two factors. One, problem orientation refers to relatively stable cognitive schemas that can be either positive or negative, and that represent the person's views about problems and his or her ability to successfully solve them. Problem-solving style refers to the activities the individual engages in when solving problems. PST distinguishes between rational, impulsive, careless, and avoidant styles, with the rational style being identified as the only one that's likely to result in adaptive problem solutions. It's characterized by a reliance on 5 skills: recognizing the problem, defining the problem, generating alternate solutions, choosing the best solution, and implementing and evaluating the chosen solution. In therapy, several strategies are used to help clients adopt a positive problem-solving orientation and rational problem-solving style, including psychoeducation, guided discussion, role-playing, and homework assignments. REM self-control therapy is a brief form of therapy that is usually conducted as a group therapy. It's based on the assumption that deficits in 3 aspects of self-control increase a person's vulnerability to depression and make it difficult to deal effectively with depressive symptoms. So first is self-monitoring. Depressed people selectively attend to negative events and to the immediate versus delayed consequences of their behavior. Self-evaluation. People who are depressed make inaccurate internal attributions and compare their behavior to standards that are excessively rigid and perfectionistic. And finally, self-reinforcement. Depressed individuals engage in low rates of self-reward and high rates of self-punishment. Therapy sessions and behavioral homework assignments correspond to the 3 aspects of self-control. During the self-monitoring phase of therapy, the client is taught to monitor negative self-statements and positive outcomes. And during the self-evaluation phase, he or she is taught to set realistic goals and to make appropriate attributions for his or her behaviors. Then finally, during the self-reinforcement phase, the client learns to reinforce him or herself with positive self-statements and activities for working toward or achieving his or her goals. Lewinson's behavioral model attributes depression to a low rate of response contingent reinforcement due to inadequate reinforcing stimuli in the environment and/or the individual's lack of skill in obtaining reinforcement. According to Lewinson, when a person's behaviors, for instance, attempts to interact with family members or coworkers, are not reinforced, those behaviors extinguish. He also proposed that in addition to eliminating or reducing certain behaviors, a low rate of response contingent reinforcement elicits pessimism, low self-esteem, and other features that are associated with depression. In terms of treatment, Lewinson initially focused on reactivating depressed patients by increasing their activity levels and access to reinforcing events, but subsequently incorporated cognitive techniques similar to those developed by Beck. Interestingly, however, there has been a renewed interest in recent years in behavioral activation approaches for depression that utilize behavioral strategies only. So 4 weeks for kids, 6 months for adults. For adults, the attachment figure could be a partner. It could even be their own child. Systematic desensitization is the first intervention we'll talk about that's based upon Wolpe's counter-conditioning. This was an application of reciprocal inhibition for eliminating anxiety responses. So what they do is they hierarchically arrange anxiety-evoking events and pair it with relaxation. So as you can see, there's 3 different sizes of spiders, and ostensibly this man has worked his way up to being able to stand near that biggest spider. Little does he know there's a much bigger spider behind him. So he may or may not be prepared for that. There are 4 stages to this process. The first is relaxation training. So the therapist needs to teach the client to use a technique that will produce relaxation. So this could be progressive relaxation, for example. And when you with this technique, you systematically tense and relax all of the body's major muscle groups. It often begins with a standard cue like, take a deep breath, or you say, I'm relaxed. Alternatively, clients may imagine a relaxing scene, such as lying on the beach on a warm, sunny day. After relaxation training is the construction of an anxiety hierarchy. So the client and therapist are going to work together to think of events related to this target behavior, so maybe being able to hold a spider, that are ordered on the basis of the amount of anxiety they evoke. So to ensure that this hierarchy represents the full range of anxiety levels and that they're also equidistant in terms of amount they will elicit. So part of why this cartoon is, funny if you think it's funny, is because you can see the spiders have been very carefully titrated in terms of how much they go up in terms of size. They're still in containers, And that's a pretty big leap to get from that, the biggest spider in the container, to the little spider coming in through the door. How do you measure that? Well, there's a scale called the Subjective Units of Distress Scale, SUDS, and this involves having the client rate each event on a scale from 0, which is complete relaxation, to 100, which is the highest level of anxiety the client can imagine. And then the events are selected on the basis of the client's rating, so that the hierarchy contains about 10 to 15 items. Third, desensitization and imagination. Relaxation is then paired with a presentation of items in the hierarchy, beginning, of course, with the least anxiety-evoking item. The therapist then instructs the client to relax, using whatever technique they learned during the first stage of treatment. Once the client has achieved the state of relaxation, the therapist instructs him or her to imagine the appropriate anxiety hierarchy item. The client signals the therapist whenever he or she feels anxious, and the therapist will help the client reestablish the relaxation. Excuse me. When the client's able to imagine an item without experiencing anxiety, then you move on in the hierarchy. So this is repeated until the client can imagine the most anxiety-arousing item without experiencing anxiety, such as that big spider coming through the door. So that's an imagination. The fourth stage is when you have been desensitized, or the client's been desensitized to about 75 to 85% of their anxiety hierarchy items. Then they begin to confront the situations in vivo, as in life, if that's actually feasible. So in vivo is highly structured and involves facing in real life only the situations that correspond to hierarchy items that have been successfully desensitized in imagination. So you're not going to throw them into something that they haven't learned to cope with, at least in their mind. So there's something called the dismantling strategy to keep in mind here. And several investigators have used this to identify what's responsible for why this works, for why this can benefit clients. And when they have used the dismantling strategy, they compare the effects of various components of treatment by administering different components to different groups. The results showed that training an incompatible response and gradual exposure to anxiety-evoking events are not the essential components of systematic desensitization, even if they might have some facilitating effect. However, it's the extinction, the repeated exposure to the conditioned stimulus without the presence of the unconditioned stimulus, that's the primary factor responsible for its effects. And Bandura actually happens to be one of the researchers who did that work, along with someone named Lang in 1969. Finally, in terms of classical conditioning interventions, we have interventions that are based on classical extinction. The two-factor theory of learning proposes, this is Maurer, M-O-W-R-E-R, 1960, proposes that the development of a phobic response is the result of both classical and operant conditioning. A person develops an anxiety reaction to a neutral stimulus when it's paired with an unconditioned stimulus that naturally elicits anxiety, or whatever aversive response, so that's the classical conditioning part. And then the operant conditioning part is the person then avoids that conditioned stimulus, like Albert's white rabbit, let's say, that the operant conditioning would kick in for little Albert when throughout his life he then never touches white animals, he avoids them. Because when he avoids those white animals, doesn't go to the zoo, leaves people's houses with white rabbits, he's enabled to avoid anxiety, which is now operant conditioning, negative reinforcement. When he leaves, that stress went away, leaving is reinforced, so people learn to avoid and escape. So the techniques, there are a number of techniques that are used to produce classical extinction, and they all involve repeatedly exposing the client to the conditioned stimulus without the unconditioned stimulus. So you're getting rid of, extinction always means you're getting rid of that pairing that caused some trouble from the past. Key to this, though, is also that element of operant conditioning, where people have learned, because it's negatively reinforced, to leave situations, to not take elevators, to walk up the stairs, even if it's many, many flights, so they don't have to deal with the conditioned response, which really just continues to amplify it. It gets worse. So three different approaches to classical extinction, and based on what we've already talked about with counter conditioning and aversive conditioning, there is, again, doing it in real life and doing it in imagination. So if you do it in real life, pairing it with the operant conditioning piece is called response prevention. So in vivo exposure with response prevention. That's a key term to remember. The client's exposed to that stimulus for a prolonged period of time. So instead of systematic desensitization, you are putting that person in an elevator and they're not leaving. For example, it can also be used with OCD, and you expose the client to obsessional cues like dirt, and you don't let them engage in their usual rituals. So they might have to sit with their hands in a bucket of dirt, and they don't get to go wash their hands under scalding hot water. So they're also not escaping. There are several variations of this. So flooding, key term, is when you're just exposed to the most anxiety or fear-arousing stimulus for a prolonged period of time. So that would, for example, be putting your hands in dirt for some folks with OCD. Graduated graded exposure is similar to systematic desensitization. It begins with exposure to situations that produce minimal anxiety, and then you progress to those that evoke more. That's helpful for reducing the fear and avoidance that can be caused by initial exposure to high anxiety arousing situations. So if a client's not ready to put their hands in a bucket of dirt, and maybe you even have them try it, it doesn't work, and they're never going to do it again, then you want to start with things that are a little bit less intense. But this is different than systematic desensitization in that they are still flooded with it. They still have to sit with 45 minutes to really address that issue. So what have studies found about in vivo with response prevention? The exposure and the response prevention are both essential. You can't have one without the other. And prolonged exposure to the anxiety-arousing stimulus is usually more effective than several brief exposures. And actually, short duration might actually increase sensitivity to fear stimulus, because then you just traumatize them without them really getting to learn, okay, that unconditioned stimulus is not here anymore. The one that caused fear. High anxiety provocation during exposure may not be necessary for it to be successful. So some investigators found that the simultaneous use of a tranquilizer, which lowers anxiety, can actually enhance it. So you're really speeding up their association, like, look, this is not necessary to feel this anxious during it. You don't need to get them anxious or than normal and then calm them down. You want them to really know, I can sit on a plane and be calm. In some situations, self-directed exposure following training by a therapist is just as effective as therapist-directed exposure. So you can prep them to go do their elevator training session, riding it up and down all day, and they don't necessarily need the therapist there. It can be just as effective for them to do it on their own. And as a clinician, you would determine, based on lots of factors, if that was the case for your client. Group exposure can also be as effective as individual treatment, and partner-assisted exposure has been found to be effective for agoraphobia and OCD. Finally, interoceptive exposure has been found effective for reducing anxiety-associated panic attacks, PTSD, and other anxiety-related disorders. So that means using strategies that are designed to evoke the feared bodily cues that are associated with fear and anxiety reactions. So spitting in a chair, breathing in a paper bag, cardiovascular exercise, for example. So people learn, I can feel dizzy, my heart can be racing, I can be out of breath, and I'm okay, because it's no longer associated with the doctor's office or the elevator. You can sit with that therapist and say, hey, I'm out of breath and I'm actually okay. All right, so that's a lot of information on in vivo exposure with response prevention. What about implosive therapy? Like in vivo exposure with response prevention, implosive therapy is based on the assumption that certain events, conditioned stimuli, are consistently avoided to reduce the anxiety that prolonged exposure would cause. Implosive therapy is conducted in the imagination, and it involves presenting the feared stimulus vividly enough so it arouses high levels of anxiety. Stampful, let's move on to the next slide. Stampful is the main developer of the implosive therapy technique, and he believed that avoiding behaviors is learned during childhood, and that it actually, there might be a fear of snakes, but it also represents a conflict that's related to sexual or aggressive impulses. So consequently, the images that you use during implosive therapy are embellished with psychodynamic themes. A snake-phobic client, for example, might be asked to imagine a scene that not only involves a personal encounter with a snake, but that also emphasizes the sexual symbolism of snakes. Research showed, however, that it really does seem like the factor that is helpful in implosive therapy is the exposure to that imagined fearful stimulus and counter-conditioning more than the sexual interpretation. Finally, we're going to talk about EMDR. There isn't a slide for this one. And the benzodiazepines, which are for anxiety. You have anxiolytics, sedative hypnotics, and non-benzo sedatives. They have their own side effects, though, which include being overly sedated or too inhibited. Now we're going to talk about other cognitive restructuring techniques, in addition to Beck, Meichenbaum, and Ellis. And the interventions described here are, they conceptualize maladaptive behaviors as the result of disturbances in thinking. They are narrower in focus and utilize a more restricted range of strategies. Thought stopping. Thought stopping entails eliminating obsessive rumination, self-criticism, depressive or anxiety-arousing ideas, and really any other unwanted or unproductive thoughts by using such techniques as covertly yelling, "Stop, stop, stop," or snapping a rubber band placed around the wrist whenever unwanted thoughts occur. Thought stopping is often combined with covert assertion, which involves making alternative, assertive self-statements following thought stopping. Stress inoculation training. This was designed to help people deal with stress by increasing their coping skills. Treatment involves 3 phases. 1, the cognitive preparation phase, also known as the conceptualization phase. It's primarily educational and involves helping the client understand his or her behavioral and cognitive responses to stressful situations. B, during the skills acquisition and rehearsal phase, the client learns and rehearses a variety of coping skills. Specific interventions during this phase include direct action techniques like relaxation, pleasant imagery, arranging escape routes, and cognitive techniques, replacing negative self-statements with coping self-statements. And C, in the final application and follow-through phase, the client applies the coping skills he or she has acquired to imagined, filmed, and in vivo stress-producing situations. So you can think of that as 1, education and cognitive preparation, 2, coping skills acquisition, and 3, application of skills in imagination and in vivo. EMDR was originally developed as an intervention for PTSD, but it's now used to treat a variety of symptoms and disorders like panic attacks, phobias, depression, and substance use. It's based on this assumption that when you're exposed to trauma, you are blocked from a very adaptive information processing mechanism that is neurophysiological. So by combining rapid lateral eye movements, which are believed to trigger that mechanism, with exposure to the trauma or fear with techniques drawn from CBT or psychodynamic, that together it can treat the trauma and reopen access to that information processing. There is controversy. It has been found to be effective for PTSD, but there's controversy as to whether this has anything to do with the eye movements, which seems and sounds a little silly, but you know what? You never know. Based on results of meta-analysis of research, Davidson and Parker have concluded that the eye movements may be unnecessary and that it's really about imaginal exposure. Self-reinforcement. Self-reinforcement is when you are administering the reinforcement to yourself. So this is something kids do for sure, but I think it especially brings up the image of adults who are trying to do weight loss or trying to lose weight, and they monitor themselves using records. There's apps on the phone now, and they start to also control their environment stimulus that they encounter to narrow the range of responses. So 2 self-management procedures is just self-monitoring and stimulus control. Those are the two pieces to really know. Self-monitoring is what you usually do initially, and this is done with CBT a lot. You're recording things, getting information about the nature and magnitude of the behavior, and that also can help you develop what your treatment is going to be before you kind of move on to stimulus control and all of that kind of stuff. Stimulus control basically means that your behavior is under stimulus control when doing it is contingent on the presence of something else. So, cigarette smoking is contingent or controlled by things like drinking coffee, talking with friends, being alone, or even having a pack of cigarettes. So when you want to use a stimulus control technique, you're altering your associations between the stimulus and the behavior. So narrowing is restricting the target behavior to a limited set of stimuli. So you can only smoke at 5 p.m. after work. That's not a great one because usually people who are smoking are trying to get rid of it altogether. But let's say with trying to lose weight, you only eat at meal times. You're not snacking and running into the kitchen and putting your hand in the bag of chips all the time. Cue strengthening. That's when you link a behavior to specific environmental conditions. Eating means sitting at the table. Studying, if you want to increase something like studying, then you cue strengthen. So when you go to your desk in the office, you study. So cue strengthening is more about increasing this particular behavior. Narrowing is usually restricting the target behavior to a limited set of stimuli. And fading consists of changing the stimulus conditions associated with the behavior. So this might be when a cat is trying to chew on your hand, you put a cat toy in their mouth. And this could also work if you have fetish objects. Give them something more appropriate. Okay, counter-conditioning is also used with what? Sex. It has been useful specifically with sexual disorders that have to do with performance anxiety. So Masters and Johnson in 1970 created something called sensate focus. And what you do is you pair situations that will evoke performance anxiety with pleasurable physical sensations and relaxation. So if it's 2 people that have become just terrified of even hugging and kissing, then you will somehow take away what makes them anxious about that so they can start to just enjoy that. So when practitioners use this technique, they typically tell the partners, no genital sex, and instead they're given homework where they take turns giving and receiving pleasure through touch. So initial assignments will mean things like massages, and you move slowly to situations that include non-demand genital touching. The research has found that sex therapy is most effective for treating premature ejaculation and vaginismus. For the former, the squeeze technique is a key component of treatment, and for the latter, a combination of relaxation and progressive dilators is actually the optimal treatment.
It's become a disorder, and they have not engaged in the behavior for 5 years or more in an uncontrolled environment, then they are in full remission. So literally they're looking at that 5-year mark, and once they hit that 5 years, then it's no longer you would do in full remission. So those are the specifiers for paraphilic disorders. Now, what are the types? These are all mentioned in the DSM-4TR, but we'll talk about them. Voyeuristic disorder, so people like to watch. Exhibitionistic disorder, people like to have others watch while they engage in some sort of sexual behavior. Frauderistic disorder, you often see that a lot in subway systems. I know in New York, you'd see it a lot where there was this, there was no consent involved. So the person rubs against or touches somebody inappropriately without consent. That is a frauderistic. So oftentimes they'll rub against another person. You see it on the subways. Like I said, it could be at a concert. It could be on a dance floor. People might do this where they literally will rub against somebody or touch them without their consent. Sexual masochism and sexual sadism. So that it involves either being sort of violated, whether it be verbal, emotional, physical, as well as being the person that violates. So there may be whips involved. There may be some sort of pain devices involved. And so, again, some people are into sadomasochism, and that is sexually related. They get pleasure off of it, sexual pleasure off of it, until it is something that causes distress or it's potential harm to themselves or another person by the fact that they haven't arranged some sort of language or the person is unable to cooperate with that, then it becomes a disorder. Pedophilic disorder, this is about prepubescent children. So pedophilic disorder, prepubescent children or around puberty, that's pedophilic disorder. Fetishistic disorder are fetishes, and there's tons of fetishes out there. Necrophilia, people who like to engage in having sex with deceased persons. Shoe fetishes, you name it, there's a fetish usually for it. So that would be a fetishistic disorder. Any type of items or dressing in a certain way. Transvestic disorder is where a heterosexual male will receive sexual gratification from either dressing in women's clothing, or it also states that having their partner or significant other or wife or whatever wearing typically masculine clothes. So they engage in activity. Either they are sexually gratified by dressing up in women's clothing and engaging in sex, or their female partner dresses up in masculine clothing or as a man or what's stereotypical of a man, and they get off on that as well. And so with transvestic disorder, it isn't about gender identity. It's purely about what is sexually gratifying to them. And so they do identify as heterosexual males. So these are the different types of paraphilic disorders. Now, moving on to substance-related and addictive disorders, what they did is they actually did expand it to gambling disorders. So that was one of those disorders in DSM-4 that they had said, well,
Aversive conditioning, or you can also think of it as aversive counter conditioning, is when the maladaptive behavior or stimulus, the conditioned stimulus, is paired with an unconditioned stimulus that naturally evokes pain or other unpleasant responses. So instead of just removing the whatever it was that was negative and adding something positive, you're actually taking something that has been conditioned to cause positive feelings and pairing it with something negative. So it's sort of the flip. And like with the other counter conditioning techniques, if you remember systematic desensitization, you can do this both in imagination and in vivo, in life. So when you're doing it in vivo, this is called overt sensitization. And when you're doing it in your imagination, not in life, it's called covert sensitization. So let's talk, so why is this used? These are typically used for behaviors that are deviant, paraphilias, for example, smoking, alcohol abuse. It's not going to be used with something like social anxiety, typically. In vivo is used to treat primarily drug and alcohol addiction, so paraphilias and self-injurious behaviors. So anti-abuse is an example of something that would be used to treat alcoholism, because when you then drink, you now have extremely unpleasant sensation and feel very sick. Eliminating a sexual fetish, whatever the object is, let's say it's a shoe, might be paired with an electric shock, so that eventually people are going to avoid, sexualizing a shoe because it produces an unpleasant sensation rather than arousal. This has been found to be moderately effective initially for some patients and some problems, like cigarette smoking. Problem is it's associated with high relapse rates and limited generalizability. So it's most successful when the aversive stimulus and its consequence is similar to the target behavior. Like nausea-inducing drugs are more effective than electric shock for treating alcoholism, and stale cigarette smoke and rapid smoking are more useful for reducing smoking than, again, an electric shock. It's also more effective when it's supplemented by booster sessions or is administered in conjunction with other treatments. And I think particularly it's worth thinking about this in terms of paraphilias, treated by combining aversion therapy with orgasmic reconditioning, relapse prevention, and other techniques that help strengthen more appropriate responses. Because this is a pretty serious problem, and whereas this might be a technique that's helpful, it's not enough, and it needs to, since aversive conditioning is sometimes thought to actually be suppressing some learning, not really getting rid of it, then you need to make sure that you continue over time to give this treatment if necessary. Covert sensitization and imagination. You want to eliminate the behavior by imagining yourself smoking. So instead of actually rapidly smoking a cigarette, you imagine yourself smoking a cigarette, and then you imagine yourself becoming nauseated, throwing up on yourself, being embarrassed, all sorts of negative things. And to help establish an alternate behavior, the therapist might also have the client envision a relief scene in which they choose not to have that cigarette on a break. They're sitting on a bench and they're just breathing the fresh air and enjoying themselves. So pleasant sensations are now associated to supplement it. Here's your key terms: positive reinforcement, thinning satiation, prompts fading, shaping versus chaining, the Premack principle, differential reinforcement, punishment habituation, overcorrection, response cost, timeout, and functional behavioral assessment. Remember the 4 quadrants of reinforcement, punishment, and then also positive, negative from learning theory. Positive means you add something, negative means you take it away. If you're reinforcing something, you want to increase that target behavior. If you're punishing something, you want to decrease that target behavior. So think about that when you look at the exam questions of what exactly the target behavior was, because it can trip you up a little bit if you don't pay attention. Factors that influence punishment, the sooner the better. Be a consistent, continuous schedule. Moderate intensity. If it's too strong, you're not going to get what you want. Avoidance, or you could even get angry, acting out even further. You don't want to do gradual increasing of the punishment because then people can get habituated and it's not effective. Similar to reinforcement, verbally clarifying. The effect is maximized when that contingent relationship is made really clear verbally. Remove all positive reinforcement. Well, punishment's going to work best when you're only getting punished, you're not getting reinforced as well. So make sure that that is also withheld. Reinforcement for alternate behavior, so this could be in your differential reinforcement category, but because punishment's teaching a person what not to do, it really is more effective if you can also combine it with reinforcement for what to do. It's important to determine if that undesirable behavior is actually just because the person has inadequate skills, because if you punish someone and they don't really know what else to do, then they need to get trained in those skills before the punishment's going to have any sort of really great effect. So overall, if we think about this, the use of punishment is mixed for a number of reasons. It's been criticized for ethical, legal, and practical reasons. For ethical reasons, some authorities consider punishment and other aversive techniques to be always unethical, but some think, you know what, if no other treatments are effective and the target behavior is really harmful, then it might be better to punish than let them keep going if it's really your only option. If someone's going to kill themselves with alcohol use, if someone is molesting children, these are cases where maybe the punishment not necessarily fits the crime, but punishment is better for fixing the crime. Also, in terms of practical considerations, you have to keep in mind that it really is suppressing a behavior and not eliminating it. So if a person learns when that punishment is going to occur and then engages in the behavior when it's going to occur, then that's unlikely, but they might go do it some other time. Punishment is also associated with several negative side effects, including fear of the punishing agent and increases in aggressiveness, negative emotions, escape, because this person is getting treated. When you are punished in life, that has impacts on you socially and emotionally, how you feel about yourself, how you feel about the world. So it's a little bit more complicated than, yay, reinforce, yay, punish. There's other things that you touch when you're reinforcing and punishing. And punishment, the negative effects of punishment really highlights that. Let's talk about types of punishment. Verbal reprimands, overcorrection, negative practice, and response cost, as well as timeout reinforcement. So let's go through these pretty quickly. Verbal reprimands. What might be a way you'd reprimand someone? Say no, say stop. This is meant to suppress unwanted behaviors in a variety of settings, but it's kind of inconsistent because reprimands can act as positive reinforcers and actually increase behavior sometimes. So if you're a kid who's not getting a lot of attention, then your mom yelling at you might not be the best kind of attention, but it's attention. Reprimands are also probably only going to cause temporary impact. You need to back it up with other things. Overcorrection is a form of positive punishment when the punishment, you're going to have to do something or something's getting added. And it can involve either one of two things. Restitution is the first, and that means that you have the individual correct any negative effects of their behavior. And positive practice requires the person to practice more appropriate behaviors, usually in an exaggerated fashion. Overcorrection often involves providing verbal instructions, and it might require constant supervision or manual guidance through the corrective behaviors, which can be problematic because that can also illustrate avoidant aggressive behaviors in themselves. So in this picture, you see a little kid giving her a massage. Well, maybe they were screaming and running around the kitchen and driving her absolutely batty, and she said, if you don't stop, then you got to give your mom a foot massage. So in some ways, this is an overcorrection because let's say stress was what they were causing their mom. Well, they have to sort of make reparations for that behavior, and they are certainly there's a manual element to that there. So there's a restitution here. They're correcting the negative effects. And positive practice of practicing more appropriate behaviors. Well, maybe this isn't something they should be doing with their mom all the time, but it is maybe a little bit more appropriate to the mom than yelling and screaming is. Fox and Azrin treated a hospitalized woman with severe retardation who constantly disrupted the ward by throwing things and overturning her bed. So when the woman engaged in this behavior, what they did was require her to straighten the entire room, which is restitution, and then to practice more desirable behaviors such as making up all the beds on the ward. So maybe with these kids, they had to say sorry to their mom. That was part of the restitution before they had the overcorrection piece, which is like giving mom a foot rub is definitely above and beyond, but hopefully helpful in learning and fun for mom. Negative practice is essentially the opposite of the positive practice component of overcorrection, and it involves requiring the individual to deliberately repeat the undesirable behavior to the point that it becomes aversive to the individual or the person is fatigued. It's especially useful for eliminating habits and other behaviors that they'd like to eliminate, like nail biting, hair twisting, pickup, motor tics, stuttering, smoking. So, as an example, when used to eliminate a motor tic, you are supposed to practice your tic rather than trying to suppress it. And then when it does occur, you repeat it for a specified period of time. So you get really sick of it, hopefully. Response cost is an application of negative punishment, and it involves removing a specific reinforcer every time the target behavior is performed. Although response cost is most commonly associated with token economies, you lose your tokens, it can be used whenever the control of positive reinforcers is possible. So a parent can use it to reduce the misbehavior of their child by taking away their computer privileges for a specified period of time, or you could decrease the allowance every time the child engages that behavior. Other examples are fines for traffic violations and late fees for paying credit card bills after the due date. Timeout is our final one. This involves removing all sources of positive reinforcement for a brief, pre-specified period of time. Teacher could do that to eliminate disruptive behaviors. Have a little part of the corner where you sit for 5 minutes. And it's usually classified as type negative punishment, but it's also considered to be a form of extinction. However, note that extinction entails continuous removal of a reinforcer from a previously reinforced response, while timeout involves removing all reinforcement for a specified period following a behavior that may or may not have been established or maintained by reinforcement. We don't know. An evaluation of timeout. Some research suggests the duration really doesn't matter. Short timeouts are effective, and longer ones are effective as longer ones. The optimal is considered to be 5 to 10 minutes. Like other forms of punishment, timeout's most effective when combined with reinforcement for alternative behaviors. So if timeout begins with a brief explanation of why it is being applied. That's a verbal clarification as well. And is there any, if you want to differentially reinforce, or not differentially reinforce, but if you wanted to add something, a positive behavior, you could teach the child to meditate when they're sitting there. That's probably not going to go great with a little kid. But maybe if you have a teenager who loves Buddhism, who somehow is getting timeouts, that would be an example. Marlatt is a cognitive behaviorist who's well known for his model of relapse prevention. Unlike AA and other abstinence-based programs, Marlatt views addiction as an overlearned habit and attempts to minimize the effects of relapses by teaching recovering addicts to view relapses as inevitable experiences. Instead of viewing recovery as all or nothing, and a relapse as due to lack of motivation or as a failure, the client is assisted to view each setback as a lapse to be learned from. Part of Marlatt's model includes identifying and assisting addicts to identify the triggers for relapse, which may involve external factors, interpersonal situations, or internal states, such as thoughts, feelings, or physiological sensations. The most common relapse trigger is thought to be the client's negative emotional state. The client is then assisted to develop new skills or behaviors for dealing with triggers, like talking to a friend instead of using drugs. Linehan's dialectical behavior therapy. Marsha Linehan's DBT is a structured outpatient therapy program for persons with borderline personality disorder. The dialectical point of view underlies the therapy, with the key dialectic being acceptance on the one hand and change on the other. The therapy is behavioral, and although the past is not ignored, the therapy focuses on present behavior and the current factors that are controlling that behavior. Therapy requires that the client agree to the following 4 conditions: to work in therapy for a specified period, typically a year, and within reason to attend all sessions. If suicidal behavior is present, to work on reducing this, to work on any behaviors that interfere with the course of therapy or therapy-interfering behaviors, and to attend skills training. The primary modes of treatment in DBT include individual therapy, telephone contact, group skills training, and therapist consultation. Individual therapy: the individual therapist is the primary therapist, with the main work of therapy being carried out during these sessions. Telephone contact is used to provide the client help and support in applying skills learned between sessions and to help find ways of avoiding self-injury. Skills training is carried out in the group context, typically with someone other than the individual therapist. The 4 groups of skills focused on are core mindfulness, interpersonal effectiveness, emotion regulation, and distress tolerance skills. Therapist consultation: therapists are required to receive DBT from each other at regular therapist consultation groups.